On, right? Thank you. So I would request Mr. Sanjay Sen to please take the session forward.
Thank you, Angana, and good evening, everyone. Am I audible?
You are.
Yes.
Yep, thanks. So today's last session is on smart hospital. There's a very famous saying that today everything is smart around us, maybe we are not. So now we are talking of smart hospital. In the initial first sessions, we had a lot of discussions by Niti Aayog and others, where it was said that we have 1.3 billion people in India. Everybody have a unique ID. How do we reach healthcare to them? So the pandemic has determined that delivery can take different forms, be it education, be it healthcare, be it food, essential items, or be it caring for your parents also. The necessity is the mother of all invention, and it has forced us to look the delivery. Now, another way that is coming is Industry 4.0. Industry 4.0 also, one of the areas of Industry 4.0 is to bring specialization to the door. So how we can achieve specialized skills across the net. Encompassing everything is how cost effective can we? Because for India, cost is an important factor, and so are the world. While delivering these type of services, we need a governance, security, data security, and privacy framework too. So what are we talking about? We are talking of remote care. We are talking about data. What to do with the data? Can we predict? Can we predict the health of a person? Can we predict how the person will behave or his health will behave? Can we put AI on that? Can we have mobile health? Today, wearables are going to different limits. How well can we use them to generate data? And last but not the least, can we use blockchain to bind all this data? And beyond all is a quality healthcare. And we are talking about smart hospital. Does hospital means only between the four walls of the hospital or beyond that? To talk about all those things, we have a very eminent panel. We will start with Dr. Shrutin. He will tell us about smart hospitals and beyond. Dr. Shrutin, please.
Hi, everyone. I hope you can hear me. Am I audible?
Okay. Yeah, you are.
So I have prepared a set of slides. Maybe I could share my screen.
Yeah, you can.
Can you see my slides?
Yes. Yeah.
Yeah, thank you. Thanks, Dr. Sanjay, for the introduction. So all of us are aware about the challenges of an ineffective health system. We see this a lot in most of the emerging markets, including India. And what happens here is right from community care until the tertiary care, we find that, of course, there are problems of access to care. There are ineffective referral systems. The disease burden goes on changing based on the demographic profile of people. And the referral is mainly sometimes not timely. And all this increases the burden of disease and how we treat and address those issues. So what, as Philips, we try and do is we look at a continuum of care, starting right from the community care until the tertiary care, and we look at kind of digitizing the pathway. So if we could digitize a pathway right from community to primary, secondary, and tertiary care, we could mainly look at and solve some of the issues that we see with ineffective healthcare delivery. And before our session, a lot of people talked about how digitization can help and how smart hospitals or Hospital 4.0, an analog of Industry 4.0, is effective in improving operational efficiency. So same way, digitizing the backbone and digitizing specific care pathways. Like say, for example, can we digitize an antenatal care pathway, for example, or can we digitize a tuberculosis care pathway or a diabetic care pathway right from community to tertiary care, so that we can not only look at preventive care, we can look at effective referrals, we look at secondary prevention if possible, and so on. Of course, because of market forces, this is seen globally. There is a rise of healthcare delivery costs. A speaker before me addressed this and how their hospital tries to solve it. Then we look at aging population, including in India. There are some cities like Mysore, for example, very close to Bangalore, where I stay. There is a significant number of old people staying alone at home, and their children are abroad. And healthcare consumerism, it's a big issue. Issue in the sense, young people, they demand healthcare as if it is some kind of an offering, just like Amazon or something else like that. And these trends actually have resulted in the hospitals, put pressure on the hospitals to become smart. And what we do as Philips is we try to partner with hospitals these days and address the quadruple aim. And what happens is we partner with hospitals in a way that we have skin in the game along with the hospital to ensure better health outcomes, improve patient experience, improve staff experience, and lower cost of care. It's exactly the problems that the speakers or the panel before us have addressed. And to go to the next slide, what we see is that hospitals in India or even in the emerging markets, they are in various stages or levels of maturity. From many of them do have an electronic medical health record system, but they may not necessarily be smart. And there are some hospitals which have integrated some of their processes, have tried to use AI in certain departments, as you may have seen the speakers before me and heard them. So these are probably reaching a stage of maturity. And of course, there are hospitals which have completely aligned with the quadruple aim and using a digital backbone to the best possible extent. And those hospitals are what we could call as smart hospitals. And of course, the patient journey starts not in the hospital, but it starts right from the community. So we call it within Philips as the healthcare continuum. And we look at almost all aspects, starting from healthy living, prevention, diagnosis, treatment, and home care. So we have solutions, for example, for pre-hospitalization, hospitalization, post-hospitalization care, and so on. And we partner, as I mentioned, with hospitals to improve operational efficiency, clinical efficiency, patient centricity, for example. And these are some of the areas that we partner with hospital on, especially radiology, that is our strength, cardiology, intensive care units, emergency department, EDs, operating rooms, outpatient and general surgery, and pharmacies. So these are areas that we see we have maximum impact when it comes to having an AI, artificial intelligence solution, along with making these systems and which can improve operational efficiencies in these particular departments. Of course, pre-hospitalization, we have several we partner with hospitals where we have developed many times virtual assistant for them, which is patients can actually chat via a chatbot, record their vital signs, then get in touch with the hospital, and then walk in for an appointment. And appointment scheduling is also a part of that. What we do is, so these are various levels of maturity when it comes to dashboards. So with the post-COVID and even in the COVID, we see that the government has actually very effectively utilized dashboards which tell us, okay, what is the number of COVID cases, how many are they increasing, those people who are treated, and so on. So hospitals in the, I would say in the pre-COVID era, they were using dashboards, but mainly developed by their own IT department. Sometime maybe in the last decade, they started having vendor partnerships or give contracts to vendors. But what we are looking as Philips going further post-COVID is that we partner with hospitals where we have skin in the game, where Philips not only partners with hospital to improve efficiency, but also share the risk. So ensure and promise hospitals that we would improve patient outcomes, for example. And of course, these are some of the areas where we use artificial intelligence in a very big way. One of them is intelligent imaging, remote patient monitoring, medication management, and communication, like some people talked about before me. So these are some of the areas. So I will not go into them. Maybe in the question answer session I could answer. I just wanted to give an overview about what we do. Post-hospitalization is a very big area where we are interested. Like telehealth is a very significant area where we partner with hospitals in delivering post-operative care and care management at home. So what we do essentially at Philips is we ensure that our partners become smart. We ensure that the partners, we partner with hospitals and we ensure patient centricity. And we basically have a digitized pathway right from the community via the primary and secondary care center to the hospital and back to the home. So that's how we cover the entire care continuum. And that's brings me to the end of the talk. It sets a sort of cadence to our discussion, and I'm looking forward to it very eagerly. Thanks for this. I would be happy to take any questions.
Thanks, Dr. Shruthen. So basically what you are saying that smart hospital is a journey and it's not a destination. And there should be a strategy and a roadmap to achieve those. And that's what...
Yeah, so typically what... Yeah, sorry. So that is typically what we have seen when we partner with hospitals, that hospitals are in different stages of maturity globally. And what we see is we first assess the level of maturity of the hospital, and then we partner with them having a skin in the game. So we actually talk about sharing revenues with them, and we ensure that the hospital revenues also increase. So that is what the game we have, and that's the reason why I talked about different levels of maturity. And typically, what we see is that the hospitals do go through these stages of evolution until they become smart.
Okay, thank you, Dr. Shruthen. We'll come back to you. Now,
Sure.
beyond the four walls of the hospital, to discuss on this and more, over to you, Jimmy.
I trust you can hear me.
No, not clear.
Similar to me a bit. Let me know if you can hear me a little better then. Still not audible?
No, you're not. There's an echo coming, Jimmy.
there's a loose connection with your microphone. We can't hear you now.
I've been trying to fix this.
Yeah, you are audible.
Great. Thanks a ton. So what I would do is also like to share, I would say, one or two key slides here, and let me know if you can see it. And rather building up of just from where Dr. Ullman left a couple of minutes back. And the focus of the discussion over the next 2-3 slides, I would rather not spend a lot on the slides, but more on the discussion here is rather say the care which is provided to patients beyond the four walls of the hospitals. And the view is definitely when we as talking about a pharma company typically look at patient being at the center of everything, and overall taking the support of the entire ecosystem, which is not only hospitals but also the care places that are there, the homes which are there, where they are staying, also the various devices which are available from the different players, but to see how we can provide a better experience to the patient. Now, from a pharma company's point of view, I would say there are two things which we are focusing on primarily, and some of that also spoken by a few speakers before. Dr. Ullman also mentioned regarding improving patient outcomes on one hand, but also I would say one of the topics we need to look at is having a more flexible supply chain to cater to the needs of the patients. I think these two are primary, I would say, top of the mind for any of the pharma companies. And now with respect to the first one, I would just quickly share one more slide, not to again get into the details here, which some of my, I would say, panelists also spoke about a couple of minutes back. But here I would focus on one or two aspects. So one is, the first one is talking about the emotional slash psychological aspect, where there is now the pharma companies and more so Bayer also working more and more with digital therapeutics companies globally to improve experience of the patient. It's by increasing engagement. It's not only about prescribing what kind of medication along with the HCPs, but also to provide, I would say, disease management, providing them enough information if they are, for example, depressed, if, example, they are nauseating, if, for example, they are under immense pain. So multiple gamifications are also available to not only focus on the physiological needs, but also on the psychological needs of the patient. So this is, I would say, outside the hospital area, just to give a better experience to the patient. And all this is possible today based on the data available coming from the patients and coming from the network of patients suffering from similar diseases. The second and the third one talk about more the physiological aspects, which is improving clinical outcomes. This is again based on more and more data. Effectively, we start off with standard protocols in the hospitals, but then with the help of more and more data, you can improve the protocols you see are much more customized in today's world. So this is where I would say, again, the digital therapeutics come into place. The third one, human error is definitely one of the topics which can be avoided. I know the entire, I would say, healthcare system is under tremendous stress, but if there is an opportunity to further reduce human error and also increase medication, adherence to medication, I think this is again with the help of digital therapeutics, which is primarily in most cases an application, is what we are trying to achieve outside the smart hospital, I would say the four walls of a hospital, and include it as an extension of a smart hospital system. The other benefits, again, I would also like to talk about here, and this is allied benefits for very, very focused on the pharma companies. It's less to do with patients, but definitely these are the byproducts of the overall digital therapeutics area. Number one, there is definitely more data available from the patient, so which helps in drug development and drug discovery for next generation products, because you see how things are progressing. At times it works, at times it doesn't work to the extent that we would like to do. Now, with as Mr. Sen mentioned a couple of minutes back, necessity is the mother of invention, and we also realized that while our sales force couldn't go and reach the HCPs in most of the cases, interestingly, most of the HCPs very quickly adapted to the more auto or digital ways of communicating. Mr. Dwivedi also spoke about it a couple of minutes back. And if we see that there is a lot of synergy that we are providing now with our sales force, they don't need to be mapped per district, per doctor, almost to that level, even going time and again to the doctor. So all this can be made available because of the smart hospitals. And this is, again, I would say, extension of what is available beyond the typical hospital care. And last but not the least, it's improving access to the HCPs, because many a times this is typically an application where the patients, the caregivers, and the pharma companies are connected. So it also improves the communication of the HCP just beyond regular periodic discussion. So in a nutshell, if I summarize, with the help of smart hospital management systems, there is definitely more benefits for the patient, and also I would say overall for the ecosystem. The one thing which I didn't include here, which again is very, very close to my heart, and it also was raised a couple of minutes back regarding the overall cost of care. And this, I would say, with the help of this system, is also is improving. How it happens? I would say now, with the help of digital therapeutics, the number of days for patient in a hospital, in a physical hospital, can be reduced, can be minimized based on the risk, obviously, and also based on the treatment. And this will also reduce the overall hospital costs. Secondly, when it comes to specifically to pharmaceutical dosage, it's not one size fits all. It's much more customized. Many a times, I would say, lesser dosage, and that's why I would say overall cost of care is also reducing. So in a nutshell, I would say it's a win-win situation for everyone, as far as and when we look at from a pharmaceutical company's point of view. I would draw your attention also to how the supply chain has changed, because I would skip the other slides, because we can go again more and more into the details, but I would rather focus on the moot point out here. If you look at the supply chain traditionally, it's been based on, again, pharma companies' view. The supply chain has been more push-based, saying do the product development, get it through the distribution, put it into the pharmacies and or to the patient. So it's a very push-based supply chain. Interestingly, now with the change, with again patient being at the center and also many a times more involved in the decision making, all of a sudden you see patient is coming at the beginning. So now it's not a push-based, but rather a pull-based supply chain. And if I just kind of summarize, there are 3-4 findings when I look at supply chain, because more and more there will be need for, I would say, more flexible supply chain, primarily for 4 differences that I see from what is today and what we would see in the next couple of years. My best guess would be in the next 2 to 3 years. So current treatment mechanism across oncology, cardiovascular, diabetes, most of this is more curative, and in the future we will see both curative as well as preventive. Secondly, when it comes to medicine delivery, and many a times involving cold chain, it's very much provided to the warehouse or the hospitals. And now the pharma companies have started thinking about providing it all the way to the home care or the homes of the patients. We spoke about it even in the previous discussion regarding more standardized protocols, and now with the help of data, we would see more and more customized protocols, which would also impact the demand of the pharmaceutical products. And I spoke about it a few minutes back regarding companies thinking more push-based supply chain, saying get the product, get it into the market, and now thinking patient at the beginning and customizing it, I would say, along the way. And what is important, again, for the pharmaceutical companies is to have end-to-end view on the supply chain. So connecting all the way from the point of sale, where the product is getting delivered to the patient, all the way back to the suppliers for API, excipients, etc., etc. I'll pause here because I would rather even open to questions later on. But in a nutshell, that's that in a nutshell covers the benefits that we see of the ecosystem, not only within the four walls of the hospital, but outside the four walls. And on the other hand, how the supply chain needs to be adapted to ensure that we are providing that level of care to the patients.
So, Jimmy, what you are saying is that a couple of things. One is gamification, which is quite new. Okay, more to enhance experience in psychological way. Digital therapeutics, which is again combining everything. Then logistics, medicine delivery at doorstep. In fact, today we have a lot of apps coming up where they are gearing up, where you can do those things. And another important thing you said is that usage of data for customized medicines. That's different actually. How do you really customize for a particular patient? Is it the dosage? And how do you use data? How can you use patient data as a pharmaceutical company and others? So those things, those questions needs to be answered in the new era of digital smart hospital systems.
Mm-hmm.
We will go to Dr. Pankaj Gupta to address some of these issues of data governance and others. Dr. Gupta, please. Dr. Gupta, you're mute. Yeah.
Thank you. Thank you for having me here today evening. And after, the such beautiful presentations, I thought I'll bring a few slides to the table for the discussion. I have done a lot of digital health transformations globally at a hospital level, at a group of hospital level. I've created smart hospitals or paperless, filmless hospitals, as they were called at one point in time, at a single hospital, group of hospitals, regional level, and at country level. My current role is trying to do it at a country level. And there is a whole lot of stuff that we are trying to do. So I thought I will have a little bit of a discussion today on what is going on at the country level, which involves a single hospital. It involves groups, regions, and what is happening outside the hospital, what is happening in the community level, and all that. So let's look at what are the levers of change here. The first lever of change I will talk about is a financial lever, or it is the health insurance side. So there's a massive change that is coming in with Ayushman Bharat coming in. And before Ayushman Bharat, the health insurance coverage in this country on the private health insurance was only 3%. And on the public health insurance, even if you include all the government schemes, about 10%, so about 13%. Now, with Ayushman Bharat coming in, we are crossing the 50% mark. We are going to about 53% of the population that is covered. And that gives a huge lever of change. Now, if the insurance starts asking the claim in a standard format, in an e-claim format, the entire market has to turn around and support it, because their payment depends on it. And in all the research that we have done, went and spoken to all the CXOs of hospitals, all the smart hospitals and not so smart hospitals, all of them said we will make changes if that is really required to be done, because the turnaround time is faster. If the turnaround time is faster, the cash in hand and the working capital improves, and they would definitely want to have that as getting it done. So that's a huge lever of change that is coming in from the government side, using the health insurance and asking for claims in a standard format, and we call it the e-claims. The second one is what happened about a year back. We were hit by a pandemic. We never thought that something like this will happen. And when it happened, we wanted the data coming from different sources, different labs, different hospitals, different clinics, to come together to be analyzed for epidemiological analysis. We were not able to do it. because everyone was storing the data in a different format. Everyone was doing their own thing. And, there had to be intermediary quick fix mechanisms that had to be put in place by the government, by the private sector, to bring the data together so that we could make sense out of the pandemic that hit us. Now, that was a huge lever of change. The government woke up and said, well, this time it happened. We make sure that next time it doesn't happen. And that is when all the standard work that was already going on in the background was brought to the fore, and the National Digital Health Mission came into being. The third lever of change is the e-governance lever. E-governance is when you layer services, healthcare services, on top of the digital platform. So Jan Dhan Aadhaar Mobile is already there. In addition to that, now what the digital backbone that is coming up based on the National Digital Health Blueprint, you can layer all the e-health services. The current one which is being rolled out are vaccines. And similarly, you can have telemedicine, you can have e-pharmacy, you can have, disease-based programs. All of them can be sort of rolled out on the rails that are laid down by the digital health. All of this digital health transformation for the new normal, as we call it, is going to be based on digital health standards. The National Digital Health Blueprint has already been published, and that carried forward the work that in the past on EHR standards, the metadata standards, the registries, and things like that. Let's go a little deeper into this. Why was this really required? Because, of course, the pandemic hit us now, but all the digital health work has been going on in terms of standards for a long time. But why? It happened because, the vertical programs wrote their IT systems in their own way. And each of the vertical program, which is, the mother and child, of course, is there. But then you have the NACO and you have the tuberculosis program and so many others. So each one of them do not talk to each other. Now, if there is a child that is born which has a low birth weight and the mother had suffered tuberculosis in the past, there is no way you can trace it, because each of the data element, each of the data pieces is in a different system and there is no traceability. Now, in 2014, there were two committees that were created, an EHR standards committee and a metadata standards committee, 2013-14 timeframe. And both of them wrote the standards and said, this has to be institutionalized. However, our entire bureaucratic process, our own, process of going through consultations and public consultations and everything took us 5 years, and it was notified in 2018, just before the launch of the Ayushman Bharat in 2018-19. And then after that, the stage was set and the National Digital Health Blueprint came in and provided the architecture. It is the, digital health architecture, how you use these standards. Having the standards is one thing, but how do you apply it? So the Digital India framework was used. And then the architecture was given that, these are the architecture principles based on which you will create applications at a single hospital level, at a regional level, or at a much larger level. Let me delve a little bit deeper. We wrote a book called Health System for New India with Niti Aayog. The chapter 5 is a digital health chapter, and I am a co-author of that. In this one, we wrote very clearly as to how the digital health transformation needs to happen. And we introduced the concept of e-objects, where the transformation needs to happen between, so if you want to send any data between provider to provider or provider to pair, the minimum set of data elements that are required to be sent, we designed it and presented it. The concept was presented in the Niti Aayog book, and then later on, we detailed it out as Access Health. And Access Health Digital is a focused group that has been working on it ever since. We have brought it out for the provider space as well as for the payer space. For the payer space, we've been working very closely with the government to get it through. For the provider space, we run a provider working group where we brought in all the large providers from the private sector as well as from the government, and try to bring consensus on these e-objects. Let me go and talk a little bit about what these e-objects are. On the pair side, e-claims is one of the e-objects which asks for claims in a standard format. Why does it need a standard format? IRDA also had a standard format, but IRDA standard format was not machine readable. Now, what we are saying is it should be machine readable. Human intervention. Now, to make it machine readable, the diagnosis has to be in a standard called ICD-10. You have to have the procedures in SNOMED CT. You need to have all the lab orders and the investigations in Loing standards. The drug orders have to be in a national drug index, and so on and so forth. In addition to that, all the data elements have to be based on metadata standards. All the demographics have to be based on the metadata standards, and so on and so forth. On the provider side, a similar construct is there, that if you want to send out a e-prescription, a standard e-prescription, then the e-prescription has to be based on e-prescription e-object. And so that the receiving side can automatically read it without any human intervention. Any e-pharmacy should be able to use it. If you want to do a telemedicine consult, then the e-encounter form needs to come out, which will carry all the notes and the prescriptions, whatever has been given by the doctor, because the doctor may have said that refer the patient to so and so higher center. The higher center needs to receive it in an electronic format and be able to process it without any human intervention. Similarly, when a patient is getting discharged from a higher center, whether it is secondary care or a tertiary care, we have e-discharge summary so that it carries the minimal information that is required at the time of discharge in an electronic format to be processed later. It can be stored in a DigiLocker, or it can be sent to a insurance, which is coupled with e-claims. So, this is the entire framework that has been put in place. It is being rolled out. And as we see, we are not talking about making one hospital smart any longer. We are talking about making the entire country smart now. And in addition to that, we have done one more thing, and that is we've come out with minimum viable product definition for the applications. So if you have to build an application, these are the minimum set of modules, minimum set of functionality that you need to have for a primary care, secondary care, or a tertiary care. What we did was we proposed that all of this should be done based on microservices. Microservices is the latest digital technology on which all your OTT platforms, all your Netflix and Amazon, they are based. It is so nimble that it will work on any platform, any hardware. It will work on your mobile, it will work on your laptop, it will work on your TV, it will work on even a larger hardware. And it requires a very small footprint to work. And any network will be able to support it. So we designed this and we put it in open source. We run an open source community in which 40 startups are working with us, implementing all of this. And we have told them that if you use these constructs, then whatever you build out of it, you have to bring it back and pour it into the open source community. And this open source community is beginning to thrive. So these are our small little changes that we are trying to make. We are an NGO working with the government, and hopefully we'll be able to contribute a little bit in transforming this huge country from where it is to a more smarter country. I will rest my case over here, and then we can take it forward in terms of discussions. Thank you so much.
Thanks, Dr. Gupta. Really, this is actually setting the backbone for the development. If you see creating the metadata, creating the objects, all those will set the foundation on which things can be built. Now, you also mentioned you're working with 40 startups to build on these type of open source so that people can be used, and also your strategy of micro coding is also very, there's an ideal way, or there's the only way to, if we really want to transform, and what we will, I am sure as a country we will, we need the help of startups. Startups will play a key role, in these transformations. While the big daddies will have their own places, the startups will have. In BCCI, we also have a program where we encourage startups, and there has been quite a success in that. One of the startups identified is Rajiv and his team. So we will try to present that what are the things that they are doing and what are the where they are trying to enable this transformation. Rajiv, over to you.
Thank you, Sanjay. Good evening, everyone. I represent Arogya Medisub Solution. We are a startup based out of Tech Incubation Center of BCCI, and what we have developed is solutions for rural India, connecting them to the hospitals, making the accessibility and affordability to the healthcare. Like, we have developed a small analyzer. This is a blood and urine analyzer, as you see on the screen. This analyzer can assess around 25 parameters, 15 in blood and 10 in urine. So, and this we have integrated, along with this, we have integrated a digital stethoscope, which can transmit the auscultation, like the heart and lung sound of the patients to the doctor remotely. And as well as we have a kitchen-shaped ECG machine, which can perform 12-lead ECG. And it can be performed by any health worker in a remote location. So, using these tools, we have, I'll come to a presentation. I'll share my screen. So, using these tools, we have Is the screen visible?
Yes. Or in a presentation mode.
So, using these tools, what we have done is we have connected very remote located places with the doctors in cities or in the cities, and thereby the patients in the remote locations can now avail the advices of the doctors, while doctors can advise them based on the evidences that are collected through the various devices that we have placed in those centers. So we, as of now, we are working at 10 locations, and while the doctors are spread across the world, means few doctors are even catering from US to the patients as remote as in villages of Arunachal Pradesh. So we are now having spokes in these states and hubs also created in each location, each states, and they are then connected with the doctors. So what in smart hospital scenario, what we were envisaging is like that patients cannot come to the hospitals or have to make quite a lot of journey to come to the hospitals or setups which are mostly in the urban localities. So they can be tapped and they can be reached by the hospitals in their own villages and catered to, and only when there is a necessity of them to be referred to the hospitals, they can be transferred to the hospitals. So thereby the entire the delivery system of medicine becomes much accessible and affordable. So these are certain, these are the ways that we do. Like in each center, these devices are located in the outreach centers. And through these devices, the A&M nurses, they can cater to, they can even do the blood test using this device out there, and collect all auscultation, patient auscultation, and ECG, BP, and everything, and register them on our telehealth platform. And the doctors in the hospital scenario or the urban centers, they can access those and write e-prescription, which is again transmitted back to these centers. The system is HIPAA compliant, and we have tried to keep all the security protocols, maintaining everything. So by this, what we have seen is it is improving the speed of execution, reducing the monitoring time, reducing the time for compliance, and reducing the operating cost, thereby making it medicine more accessible and affordable. So this is a portal that we use, the telehealth portal, where we have a hub and spoke model, and doctors can access it through the hub user access. Hello? Am I audible?
Yes.
Yeah. So the doctors can use it from the like hub user module, while the nurses and the NM ASHA workers, they use the spoke user module and cater to the patient in their villages. So this is a system which can be like, it's very easily lightweight, like the entire thing. When all these devices that you are seeing can be packed in a backpack and be carried, and the total weight is less than around 2 kilos. So it can be easily taken like on a cycle ride or a bike and taken to very remote locations. Even by walking also, some locations are catered. It's very easy to use by the, even like since the interfaces are more or less like a mobile phone. So the nurses or the local people, they find it quite easy to use them. And all of the devices works on its inbuilt battery. So the requirement of power at the stations are not that much. We train the people, we provide online supports, we supply the devices, and then we connect the hospitals with their outreach centers and let them operate on their own. That's how we the model that we follow and we are serving. So these are certain glimpses from the different clinics that are being run. So we have our endeavors in Northeast, that is Arunachal Pradesh, recently won the district National Digital Award 2020 Gold. We got awarded from Bengal government in Bengalathon 2018, from where our journey started. These are the different clients and partnerships that we are currently having. So I'll leave that out here, and I'll be open for questions, and if any queries are there, I'll be happy to answer.
Excellent, Rajiv. Excellent.
Thank you.
Now we can open the floor for questions and discussions. Angana?
There, and there were some questions which I posted in the chat, which come from the audience. You may please also refer to them. Like, patient data storage is better in local servers or cloud server?
Dr. Gupta, one of the questions that was asked is that do we store that patient's data locally or in the cloud? Because as we know that both have its advantages and disadvantages, and if we are into the cloud, what are the do's and don'ts that we need to follow?
The National Digital Health Blueprint, as I mentioned, is cloud first, mobile first. That is the two basic principles that are laid out in the blueprint. So gone are the days when you used to design for the desktop. Gone are the days when you used to design for a single application, which is a local install. We now need to design, and that is a demand that is being put by the National Digital Health Blueprint, that please design your application, which is cloud first and mobile first. Of course, it can run on any other platform other than mobile, but you must design it. The first design principle is that it has to be running on the mobile. Mobile is not an afterthought. Similarly, cloud is not an afterthought. It has to be designed for cloud, and it can, of course, run on local install. Now, given that, there's another principle that is laid out in National Digital Health Blueprint, and that is a federated architecture. The federated architecture tells you that you need to have your application data stored locally and shared nationally. So what that means is, without the cloud, you just cannot do it. You have to have a cloud interface. You need to have the cloud built in, but also you need to have the privacy and security principles built in, so that more than privacy, I would stress on security. The data security is the most important thing. You do not want the data to be accessed by people who do not have access, or who should not have access to it. And that these are small, simple things. How to do it is all written in the blueprint. If somebody goes through it, all the hows are written in that.
Thank you,
Thanks,
sir.
Dr. Another question is for Rajiv. Rajiv, what are the plans of scaling this up? Rajiv?
Next. Rajiv is there. Rajiv,
Is there?
can you hear? Somehow it's not responding, but he's showing on the. The other question is, technology's role in COVID-19 vaccine transportation. Like, would you like to address this? It's like, I think it might be very broad, but, up to the discretion of the chairperson.
Jimmy, will you like to take it?
I'll try to give it based on the other broader experience as far as distribution is concerned. So definitely we see two I would say trends over there. As I spoke a little bit about the flexible supply chain, I think more and more we have tried moving towards that, and with the help of third-party players. So primarily, if you look at the companies like, I'll just give one example. DHL is now investing heavily because now they even have they even have GMP, I would say, certifications in a few areas. So which I would say typically one pharma company, it's very, very difficult to do. So you see now we're extending more and more with the support of the third-party partners. So I know Maersk is also doing, DHL is also doing. So that's number one. And so using that distribution. Now, as far as technology is concerned, I would say, again, this is end-to-end connectivity of data. If you see, there are even now paper-based labels which are used for tracking. So the world has moved to a paper-based label. So even the SIM card, which is as thin as a paper, you just put it on the vaccine more for traceability. That is coming handy to understand the exact movement and to even kind of see how fast it is going. Now, so on the distribution side, again, we use more and more of these third-party partners, but from a technology point of view to track and trace, this is the kind of technology which we are using. If I would like to qualify that, we are still far away, I would say, to the extent where we want to be, because this is more a nascent technology. The backbone and all, which Dr. Gupta mentioned earlier, is still to be developed. I would say we are still a couple of years away from having that end-to-end view. But so I would rest my case on that. I would say there's still some progress going on, but in the current situation, it's one step at a time.
It's just the beginning.
This is just the beginning.
Dr. Shrutin, we'd like to understand that how much time typically in a journey from a brick and mortar hospital to a smart hospital transition typically takes. And especially, is it a chain that rolls out, or it is hospital by hospital that do it? What are the typical models that you recommend?
Yeah, that's a difficult question to answer, but let me attempt it. So what we have done is, we have looked at diseases as as digitization of a disease backbone. Like, say, for example, we started with mother and child care, mainly antenatal care. So we looked at digitizing the entire pathway, right from infertility care until until a lady becomes pregnant, then all the 3 trimesters of pregnancy, then labor and delivery, and then post-natal care until the child is 2 years of age. So we digitized the entire care pathway. We tried doing it first in Indonesia, then we did it in India in some centers, and then we did it in Africa. So what we have, after gaining those experiences over, I would say, the last 15 years, what we have done is maybe over the last 5 years, we started entering into more of tertiary care hospitals, and then partnering with them for revenue generation and for having skin in the game was a big, I would say, a risk that was taken by the company in general, because we were mainly vendors initially, but to partner with a company, with a provider, and then to understand their problems thoroughly, look at how we can optimize their operations, look at improving clinical efficiency. So that itself would take some time. So what we have is we have a few successes, and the journey has become even more stronger. But to answer your question in a nutshell, it typically would take at least 2 to 3 years of rigorously working with a partner and then understanding one particular clinical pathway, and then to make that pathway smart. So that is what I have and my team has learned over our experiences with working with partners.
Oh, really, that was really, I never thought of it actually. This is a way to go. Thanks for enlightening us, Dr. Shrutan.
Thank you.
Yeah. Dr. Gupta, the question is that we are a 1.3 billion people country. Carrying healthcare to the remote corner of from Kashmir to Kanyakumari is a daunting task. What are the 2-3 things that we all of us should do in order to achieve that? Because I believe that each of us has some responsibility from a social aspect or the way we do it, what we need to do.
Sure. It is definitely a daunting task. Now, to really adopt the change that is coming, government can do only so much. Government has done its bit this time. You know, every time while I was working in the private sector, it was our, best hobby to blame the government that they don't do it. But this time around, the government has done their bit. It is for the private sector to stand up. It is for the common man to stand up and adopt it now. Now, it is time to go and pick up those pieces. Of course, there will be flaws initially. Of course, it will take time to stabilize. But then, give it time. Give it time to stabilize. Whatever has been provided, use it. Unless you use it, the data will not become available to get stabilized. If you shun it in the beginning, then it's a non-starter. This is every time that I say that, the 40 startups that work with me, when the first time I gave a call, please come and join me, they said, Saab, ye India, ye hoga kya? Aap bol rahe ho, lekin theek hai, lekin hoga kya? Today, when I ask them, I don't pay them even a single penny. They're with me standing firmly and implementing all that. I ask them why. Because we do this regular, customer feedback and all the feedbacks from our startups. I asked them why. Why are you still standing? They said, "Saab, हमारा business तो पता नहीं कहाँ का कहाँ चला गया." मतलब, what the government rolls out, we are already there. We are ready. We are already, sort of energized, and we are putting all the building blocks already in place. So, it is for now the individual to stand up and say, me first. Can I get it? So that those are the only two things that I would like to say. That government has done its bit. It's for now us to stand up and adopt it.
Doctor. Rajiv, a question to you. What's the plan of scaling this up?
Okay, so what we are doing is we are already got into the primary segment, like primary initial rollouts. Now we are trying to get into the government programs, outreach centers with the hospitals. That's what we are building. We have also started approaching a lot of MNCs with their different programs like CSR programs or the sustainable growth programs. And even we have reached few overseas clients in Africa, where we are doing certain installations. So that's how we are expanding now.
Okay. Angana, if there are no more questions, I would like to thank each and every participant from the bottom of my heart. It was really, really a enlightening session for me, and I am sure all those people who are listening to us. Okay, and also health is wealth. And I think by this we are creating wealth for the country at large. And I wish this goes on and life goes on. Thank you very much for joining this session on behalf of BCCL. Thank you very much.
Thank you.
Thank you, everybody.
Thank you.
Thank you.
Thank you. Good night.
Tomorrow's sessions are on Korea's K-Quarantine ICT Solution 2020 and panel discussion on role of technology in care, caution, prevention in normal life, and technology adoption in healthcare delivery in cardiovascular and immunology and rheumatology. It will start from 3:45 p.m. IST. So we look forward to having you with us. Thank you.
Thank you.